Hello, and thank you for joining us in this webinar on oZTEo for MR bone imaging. I'm Rob Peters from GE Healthcare, and on behalf of my colleague Maggie Fung, we welcome you to this clinical panel discussion on oZTEo, delivering a one-stop shop for orthopedic imaging. Thus far, MR has primarily been a soft tissue imaging modality where tissues such as cortical bone, ligaments, tendons, and calcifications were assessed from the signal void in the image. The reason is these hard tissues usually have extremely short T2s, which means that their signal has decayed by the time of signal detection of conventional MR pulse sequences. To circumvent this historical limitation, oZTEo uses a radial zero-TE technique, thus the name. In fact, it is based on the same sequence as our industry-first silent scan. With this technique, as you will see, we have a new contrast to explore in which images can be made of bone morphology and other related things such as calcification, ossification, and fractures. Overall, we see oZTEo as complementing the conventional MR soft tissue exam, all with perfect co-registration. You will see some great examples of volume rendering using our volume illumination tool. Finally, oZTEo is available for all anatomies, and as it is MR, does not use ionizing radiation. So let's take a look at some examples of oZTEo to give you a sense of its capabilities. Here we see some examples showing FAI measurements in the hip, ossification of the longitudinal ligament in the spine, and a glenoid fracture of the shoulder. It's truly difficult to believe that these are MR images. In fact, when we compare these images with a CT of the same patient, we see a very striking similarity. You'll see more of this in the upcoming speaker presentations. oZTEo is a software application that is available in our latest SignaWorks AirIQ Edition software release. Other MSK-related features in this release that you may find useful include HyperMaverick SL, for enabling fast 3D isotropic acquisitions in the vicinity of MR conditional implants, HyperSense acceleration for some new 3D sequences, AirX knee for automated and consistent slice placements, and of course, our pioneering new deep learning-based AirRecon DL for improving SNR and image sharpness, enabling shorter acquisition times and proven to be particularly effective for MSK imaging. The oZTEo application is also compatible with most systems of our MR portfolio for 1.5T, 3T, and 7T. So let's meet our distinguished speakers for this clinical panel discussion. Each has used the oZTEo bone imaging application extensively, whether in research and/or clinical practice. We will start with Dr. Eric Chang from the UCSD and VA San Diego healthcare system, whose lab is one of GE's research collaboration sites for UTE and ZTE technical development. Then over to Dr. Houston Aydinguz from the Hacettepe University School of Medicine in Ankara, Turkey, who was one of our first clinical pilot evaluation sites, providing a wealth of clinical evaluation over a very broad spectrum of patients. Next will be Dr. Jesse Sandberg from Lucile Packard Children's Hospital and Stanford University, who will share his experiences with using oZTEo for pediatrics. And finally, to Dr. Hollis Potter from Hospital for Special Surgery, whose lab has helped co-develop oZTEo from the very beginning and really provided us with the green light to proceed with this new clinical application. Dr. Chang, I hand it over to you.
Thanks, Rob and Maggie. Imaging bone is important. CT is most typically used, but radiation is a concern. For the spine, if you image the neck, the thyroid is irradiated. If you image the thoracic or lumbar spine, other radiosensitive organs are irradiated, such as the breasts. If you image one shoulder, both shoulders are irradiated, as well as the thyroid and parts of the breasts. The effective radiation doses can be quite high. For a CT of the spine, average effective dose, according to the ACR, is around 9 millisieverts. And studies have found that average effective dose from a CT shoulder exam is around 11 millisieverts. This is about 3 to 4 years of background radiation per exam. And according to a study a few years ago, lifetime attributable risk of cancer from a single shoulder CT was estimated at 0.6 to 0.7 per thousand. The clinical need is so high, though, that CT of the spine and shoulders are performed daily. A frequent indication for these CT exams is preoperative assessment. For the spine, surgeons rely on MRI for the cord and nerves. For the shoulder, surgeons rely on MRI for soft tissues like the rotator cuff, muscles, and labrum. CT is then performed to visualize the margins of bone. Radiation is a concern, but another is that the patient has to come back in addition to their MRI appointment, which results in more lost time and costs for the patient and society as a whole. This is a great imaging opportunity for osteo. For potentially operative cases, we can use osteo to make MRI a one-stop shop. Let's jump into some cases to illustrate this. Here's a case of a 55-year-old man with chronic neck pain and myelopathic symptoms. We're scrolling from right to left. Now we're seeing an inverted window, which some have suggested displays bone as well as osteo images, which you can see is a much better so-called CT-like image, scrolling from left to right. Notice the extensive ossification of the posterior longitudinal ligament, which is not well seen on the longer echo time images. This is because many structures are dark or below the noise floor on longer echo time images, including ligaments, tendons, and annulus fibrosis regions, in addition to bone. ZTE obtains signal from all of these structures so they can be separated to mostly highlight bone. And it's an isotropic acquisition as well, so you can do multiplanar reformats. All of the bone findings in this case were confirmed by CT. Ossification of the posterior longitudinal ligament is not a rare phenomenon, and identification of these foci of bone is important to guide surgical decision-making and to minimize complications, such as dural tears or failed surgeries. It's well known that MRI can miss or underestimate intracanalicular bone, but we found that osteo can pick these up pretty accurately. The shoulder is another area where osteo can be particularly useful. Here's a case of a 38-year-old man with shoulder instability. He has a very large Hill-Sachs lesion. Without the images labeled, it's easy to believe that all of these are CT images. But as you can see on the image on the upper left, there's the CT, whereas the rest are osteo at different isotropic resolutions, all with high-quality CT-like contrast. Because this is a 3D sequence, we can use osteo for image reformats in different planes, whereas with 2D sequences, we have to rely on the correct imaging plane prescription during the scan. 3D osteo, we can post-process and obtain a true on-FOSS glenoid view after the acquisition, and also evaluate the large Hill-Sachs lesion in different imaging planes. Here are images from a 22-year-old man with chronic shoulder instability. On this MR arthrogram, you can see a chronic Bankart lesion, but the bone margins are not well defined enough to measure. This is the reason why CT is often obtained. In the same case with the multiplanar osteo images side by side with the CT, the glenoid margins and fracture fragments are obvious. For glenoid bone stock, multiple studies have shown that volume rendered CT is the gold standard imaging technique by which to make the most accurate measures. With conventional MR images, though, post-processing times can be pretty lengthy. This pretty much precludes their use in routine clinical practice. Here I'm showing volume rendered CT data on the left and a rendering from the osteo images on the right. I'm showing examples of manual segmentation of the glenoid in real time. For the osteo sequence, windowing and leveling displays the bone. Usually I don't spend too much time cleaning it up at this point, but have it windowed sufficiently to see the glenohumeral joint and to segment it to a smaller volume. From here, I manually remove the humerus, and this leaves an on-FOSS glenoid view where we can improve the windowing and leveling to obtain a nice volume rendered image of the glenoid. At this point, it's easy to make a variety of measurements, which can be saved or altogether performed by the surgical team. You'll notice that each of these took about 45 seconds. In real life, this can vary from half a minute to a minute, depending on the particular software, the user experience level, the patient anatomy, and how clean you want the images. But for sure, rendering of osteo images is easy to incorporate into the clinical workflow. I'd like to point out that there are a variety of softwares that may make this even easier. There are developments in the pipeline, such as deep learning segmentation, which would entirely eliminate the archaic manual segmentation methods. Here's an example of a 29-year-old man with instability and glenoid bone loss. In this study and in this example, we found almost perfect intermodality agreement between 3D CT and 3D osteo. Thank you for your attention. I'd also like to acknowledge my lab group, individuals who have put work into this talk, and GE for all the support that got us to this point.
Thank you, Rob and Maggie. I'm going to be sharing with you our experience about zero echo time imaging in musculoskeletal MRI. I'm going to show you some clinical applications, and I will also show you some pitfalls of this very promising sequence. So let me show you a couple of examples first, and then I will come to perhaps some of the pitfalls. We have a lot of musculoskeletal patients within a very wide spectrum, ranging from traumatic to degenerative to inflammatory, oncologic, and we started to use ZTE almost on a daily basis. We incorporated it into most of our protocols for the last year. And one of the things that we use it for is, for example, alpha angle measurement for cam-type femoral acetabular impingement. And you're seeing here an inverted thick slab reformatted coronal minimum intensity projection ZTE image, which is quite similar to this radiograph here, the anterior-posterior pelvic radiograph. And from a workstation, we are able to select the exact location where we would like to measure the radial reformat that you see here to measure the alpha angle. These were all ZTE images. Another application that we use it for is actually for critical shoulder angle measurement. And you can see here that we are using this in a workstation, and we are actually cross-referencing our major reference points with the other MR images also, and we are selecting the exact location for this type of angle measurements. And this is one of the applications that we use almost on a daily basis. As Dr. Chang already touched upon, we are also using this for Osseous Bankart lesions. You are seeing an ZTE here, which is quite comparable to this CT here. And this en-face view here from CT is also very much like the ZT image that we have here. The interesting thing here is you can also pick up this smaller bone fragment here in this particular patient with an Osseous Bankart lesion. And sure enough, we are also using this for glenoid stock estimation and also glenoid track assessment. And for the glenoid track assessment, we also make use of the possibility of cross-referencing the ZTE image with another axial image, as you can see here, a proton density fat suppressed image, to ascertain the exact location of the medial edge of the rotator cuff footprint, so that we will be measuring the heel sags interval to the best advantage. And this is quite easy with ZTE with no need to take an additional CT. Here in this patient with diffuse osteoporosis, you are seeing that the ZT, which is quite comparable to the CT image right here. This is something that we have done for the ACL reconstruction here, the CT arthrogram here. And you're seeing that there are these areas in the bone which are not so conspicuous on the T1 weighted image, but then they appear on this T2 fat set image. And then you are seeing that the images here of the ZT and CT are quite comparable in this regard, in showing the diffuse osteoporosis and different manifestations of diffuse osteoporosis. Erosions in inflammatory disorders, in inflammatory arthropathies, I mean, are quite conspicuous with ZTE, as you can see here in this patient with seronegative inflammatory arthritis. You can appreciate osteitis, synovitis, and also lots of erosions which are not all well visible even on a radiograph, but then they are nicely depicted on this ZT image as shown here. These point to the erosions. Likewise, erosions in the sacroiliac joints in almost any age group, including the kids, where it's really a challenge with the ossification going on. They are also well visible with ZT sequence here. You can see it here. not so well visible on this T1 weighted image here, and also on the T2 weighted fat suppressed image. Another patient with sacroiliac erosions. This patient had an active sacroiliitis some 3 years earlier, but then you see that there is the structural damage lesions here, the erosions, which are also nicely depicted on this T1 fat set image, but then they are shown almost with CT-like clarity on the ZTE sequence here, which also shows the subchondral sclerosis along with the erosions. Gout is also another inflammatory arthropathy that we can make use of ZTE as shown here. The punched out erosions are nicely depicted with the presence of other conditions going on there, like the tophi. And some of the joint cartilage calcifications, they are also nicely depicted with ZTE, as shown here in this patient. There is the surface deposition of some minerals, as you can see here, which has been verified with CT, which is quite comparable to the ZTE reformat here. Since this is an isotropic 3D sequence, we are capable of doing lots of reformats to our wish, actually. Dystrophic calcifications are another condition that you can make use of ZTE. This is a CT image on the right. This is a ZTE image. And this is a radiograph in this 31-year-old man with an old burn scar in his right leg. The MRI was done for looking for infection, actually. But then, as you can see, the ZTE nicely depicts the soft tissue dystrophic calcifications, which are not so well visible on the T1 weighted image here. And also they were not well visible on the T2 weighted fat suppressed images. Osteosarcoma definitely benefits from ZTE, and you can see that it shows the osteoid, the matrix there, the bone matrix in this particular condition. This is from a PET CT actually, and this is an X-ray, and you can see that these are quite comparable when you compare them with the STIR image. The osteoid matrix there is nicely depicted. In this patient with periosteal sleeve avulsion of the distal clavicle, we could make the diagnosis in a more sure manner, because you can see that in this particular ZT image, and this was confirmed with CT, there is not a cortical fracture, but rather it is a periosteal avulsion by the capsule of the distal clavicle right here. And we are sometimes seeing the lack of a mineralized fracture as nicely depicted in this particular patient. In this particular patient, we are coming to one of the pitfalls here now. You can see that there is some gas within the joint space, and these are depicted as those white foci, which may be sometimes perhaps mistaken for some bone fragments, especially with intra-articular fractures. So one of the pitfalls of ZTE is obviously the presence of gas within the tissues, and we should definitely look for other clues to its presence, like the other sequences or sometimes the other imaging methods like the X-rays. Micrometallic debris artifacts is another, they are another condition where there's a pitfall with ZTE. You would actually have them appear white, as shown in this particular patient who had undergone an ACL reconstruction. And this blooming artifact right here and here and here point to the presence of these artifacts. Once again, correlation is very important. Hemosiderin deposition, either with hemophilia B here, as here, and with pigmented villonodular synovitis, which is better known as tenosynovial giant cell tumor, they may sometimes be seen in a pitfall manner, like in a more whitish manner, if you will, on the inverted ZTE sequence. So these are some of the examples that we have seen in the last year, and it has been a pleasure for me to share them with you.
Thank you for the invitation. It's great to be here. Today I'll be discussing pediatric applications of osteoZTE. A little background, pathologic evaluation in pediatric patients often requires imaging beyond standard radiography. MRI is often performed due to the modality's inherent high soft tissue contrast, ability to evaluate bone marrow, non-ionizing radiation technique. However, standard MR pulse sequences generally have poor cortical bone contrast. Thus, CT is classically acquired to further evaluate cortical structures when needed, such as in pre-surgical planning. The drawback being is ionizing radiation, which is obviously not ideal for pediatric patients. The application of an MRI sequence with cortical bone contrast would avoid ionizing radiation and may avoid the need for multimodal cross-sectional imaging. What are some difficulties with osteoZTE in the pediatric population? Well, they're smaller people and they have smaller anatomy. And so this has the potential for decreased resolution. However, with modern coils and 3T scanners, this has helped stave off the resolution issues to a degree. And also in comparison to adults, children generally have thinner cortex and more skeletal cartilage. And this is especially true around joints such as the hips and knees. And this can be problematic when attempting to do 3D reconstructions. So getting on to the actual applications of pediatric osteo, the main three categories you kind of group them in is chest imaging, musculoskeletal imaging, and neuroimaging. And the neuroimaging being, the cranium, looking at the brain, the bone structures and the sutures, as well as the facial bones. However, today I'm going to really be focusing on musculoskeletal imaging. I'm a musculoskeletal radiologist, and I'll be discussing cases, and they'll all fit one of these categories, either diagnosis, pre-surgical planning, or follow-up. So just keep that in mind. So what are the actual applications? So we found it to be very helpful in temporomandibular joint imaging, in particular in juvenile rheumatoid arthritis evaluation. Other aspects that we've used it in is the hips, looking at general pathology, hip dysplasia, FAI, and then just general extremity exams, looking at osteoid osteomas, OCDs, coalition, et cetera. Now going into the actual cases, starting off at the TMJ. How we acquire it, we acquire the native ZTE in the coronal plane and then reconstruct in coronal oblique and sagittal oblique so we could well profile the TMJ. A little bit about juvenile rheumatoid arthritis. It's the most common arthritis in childhood. The TMJ is often involved in the disease process. Imaging findings include synovitis, joint effusion, osteitis, joint subluxation, and osseous erosions. What we're actually looking for in the osseo sequence is looking at the TMJ mandibular condyle morphology, looking for erosions, remodeling, and flattening. Now, this is a 15-year-old boy being evaluated for possible JIA after abnormal CT panorex, which you can see on the left here. And in the left here, we see that the mandibular condyle is flattened with multiple erosions when compared to the right side, where the mandibular condyle has a nice convex morphology, and we see the cortex well. This is a 14-year-old boy with left hip pain following soccer injury. We see here on the initial radiograph this possible cortical irregularity along the inferior aspect of the acetabulum. Patient continued to have pain, so an MRI was performed. And on our standard sequences, we see that the labrum has avulsed off the bone, and slightly more inferiorly on the T1 sequence, we see this additional T1 dark structure. Now, the question is this a labrum or is this bone? Now, using the osteo sequence, we see that it's a bright structure, and this is just the corresponding T1 images showing it's dark. Thus, the osteo confirms that this is a bone fragment and not labrum, and this is likely secondary to a transient hip dislocation. Of note, on T1, cortical bone and labrum is dark, and on the osteo sequence, the cortical bone is bright and labrum, has nearly no signal. And so this avulsed labrum is attached to the bone fragment. All right, now moving on to the general extremities. This is an interesting case, a 2-year-old boy with inability to bear weight, leg pain, and subjective fevers, clinical concern for osteomyelitis. This was a case that happened during the weekend, of course. So initial radiograph is essentially normal. Thus, in these type of cases, of course, we go to MRI. And on our standard sequence, we see edema and enhancement within the intramedullary and adjacent soft tissue region. We also have a subperiosteal fluid collection. And on our STIR, we just see kind of the extent of what's going on. So initially thought to be osteomyelitis, especially given the history and the initial imaging that was provided. An osteosequence was performed, and we clearly see that there is a spiral appearing cortical defect coursing along the diaphysis. And again, this is our plain radiograph that was performed. Now, if we use this osteo sequence and do a race summation with a 20 millimeter thick slab, we could create an X-ray like image, and we could see this spiral pattern. And this was diagnosed to be an unwitnessed fall resulting in a radiographically occult femoral spiral fracture. So as we all know, history is somewhat a little off and when we get any case. Moving on to an 8-month-old boy, immunocompromised with fever and ankle swelling. This kiddo was diagnosed with non-MTB osteomyelitis. And so in our pre-treatment examination, we see increased edema in the region of the distal fibula. This is ankle. And in our osseo sequence, we clearly see that there's a cortical and intramedullary osseous destruction. The kid got treated with appropriate therapy, and we could see a well-healed distal fibula and we can see the good cortex of the bone. Moving on to a couple of cases in the feet. This is a 13-year-old girl with a partially treated calcaneal aneurysmal bone cyst, which we have been acquiring images on to follow up bone incorporation and graft material. So I only showed one time frame here, but we can see that there's incorporation of bone graft material. And then comparable imaging on the CT. On the right is a 17-year-old girl with cuboid osteoid osteoma. This patient subsequently underwent IR ablation procedure. So this is good for pre-surgical planning. A couple more cases in the feet. The left is an 11-year-old boy presenting with left foot pain and was found to have a fibrous coalition of the middle subtalar joint. We can see the irregularity of the middle subtalar joint here. And lastly, this is a 15-year-old girl with a talar dome OCD who's been getting followed up to assess healing of the osteochondritis dissecans lesion. And we could see well the parent and the progeny bone and the corresponding CT image. So in conclusion, osteoZTE has a variety of applications in pediatric imaging, such as in evaluation of the MSK system. This is particularly in the joints, such as the TMJ and hips, as well as in the general extremities. Osteo is helpful in different stages of imaging evaluation, whether it be in diagnosis of a condition for pre-surgical planning or for follow-up imaging. Thank you for your attention.
Thank you, Rob and Maggie. It's a pleasure to talk about the clinical adoption, validation, and future of osteo. So as the previous speakers have indicated, CT is commonly used and often in young individuals where we have to be careful about cumulative radiation burden. MR is often used to evaluate the soft tissue envelope in these patients as well. So they're indeed very complementary. And as the previous speakers have indicated, ZTE or osteo can obviate the need for ionizing radiation. In the foot and ankle, we've added it to all of our evaluation for high ankle sprain, looking for subtle occult fractures, certainly in a midfoot injury for Liz Frank, looking for subtle fractures of the tarsal and metatarsal joints. In the shoulder, clearly an instability as the previous speakers have shown, but also we've used it very effectively in planning for the appropriate measurements for a shoulder arthroplasty. So in order to be adopted by the orthopedic community, they have to be comfortable that it's been validated against the standard that they're comfortable in their usual algorithm, and that is going to be CT. So the first place that we employed this was in the shoulder. And we looked at the appropriate measurements that are used from CT and actually measured those on the osteo. And that included glenoid vault depth, the depth and breadth of the Bankart and the Hill-Sachs lesion, looking for on track versus off track, and trying to get a sense of the bony deficiency that they would need to do some sort of an augmentation procedure. And we saw very good reproducibility, but also agreement, intermodal agreement between the MRI osteo and the CT. I'm going to show you some examples from the ankle and the foot. These have been reported at a scientific meeting and are submitted for publication. This is a subtle posterior malleolar fracture, I think nicely demonstrated here on the osteo. And here we can see a spiral Weber B fracture associated with syndesmotic injury. And you can see this cortical avulsion that might be hard to glean off the sagittal intermediate or proton density weighted image, but is nicely seen, not only the red arrows on the spiral fracture, but that displaced fragment that may be problematic. This is a posterior malleolar fracture with segmented depression, comparing the cartilage sensitive sagittal PD with the osteo, showing you that offset. So again, very complementary information, giving you this one-stop shopping. What's fun to do with this, and a way we attracted this to our orthopedic community, is we would put the osteo images in, they would see them on PACS, and they call me up and say, Hollis, did you get a CT on this patient? So it's fun to fool the surgeons, and that's often an effective marketing way to try to increase their referral base for the osteo. So this is showing you inter-reader reliability as well as intermodal reliability. And these are the kind of data that I can take out and show the foot and ankle service to say, look, this is accurate based on a standard that you recognize that and then you're comfortable with. So we saw almost perfect agreement when we evaluated not only the findings of CT and osteo, but to the surgical findings. So again, showing them validation was something that they're comfortable with. There was one false negative of posterior malleolar fracture and one false positive, but we saw very good raw agreement with good reproducibility. So we concluded, at least in the foot and ankle, that the ZT provides high contrast, very similar to the data that we have in the shoulder. It was non-inferior to CT in the characterization fractures. And in fact, fracture fragments were repeatable between raters of varying experience, which is nice. It becomes the high contrast allows it very easy to discern these subtle fracture fragments. So you don't have to be a senior MR radiologist to interpret these images. So we also wanted to address hip, as some of the other speakers had done. And as other speakers have indicated, developmental dysplasia and femoroacetabular impingement can occur in young individuals who are trying to be cognizant of radiation burden. So we looked at a study, and this is reported in AJSM in 36 hips from 22 patients. And again, just going back and forth, I love to show this image to surgeons, kind of morphing back and forth, because they really can't tell the difference between it. And again, it's that fun of fooling the surgeons, but also making them recognize this is something they can be comfortable with. So we used, these images are very amenable to MPRs. So here we have the axial acquired, we can get sagittal and coronal images, and this is similar to the reformations the other speakers have shown. We can get center edge angle, we can get acetabular version at 1, 2, and 3 o'clock, and this is standard off of our CT algorithm. Now we're just doing it all on MR. We're getting alpha and beta measurements in these patients, and this is showing you inter-reader. So again, for validation, we want to show that not only we agree with CT, but in fact, the measurements we glean off the MR data are reproducible. And again, showing intermodal agreement, again, with good reproducibility across all these different and clinically relevant angular measurements. We can also create 3D models, looking for these subtle areas of insufficient offset and those characteristic intraosseous gangliocysts C and FAI cohorts. So thinking to the future, once we've got the surgeons on the fishing line, so to speak, how do we take it further? Well, if we can create 3D models, then we can actually make some predictive models in silico. So the flexion adduction internal rotation test is a very common test that's done to assess for patients with pain with femoroacetabular impingement. In silico now, we can take these 3D models and bring them to 90 degrees of flexion and then do iterative amounts of adduction of the hip and internal rotation. And this is looking at proximity calculations where we get these increased contact pressures as the hip is at 90 degrees now is put into greater degree of internal rotation and adduction. So we asked the clinical question, do any one of the osseous joint morphological measurements that we can make now completely on MR or on CT, do they correlate in silico with simulated range of motion? The objective was whether any one of these angular measurements correlate with simulated range of motion, and our hypothesis is that individual measurements were insufficient. So we recruited 32 hips from 16 consecutive patients. They had prior or scheduled concurrent CT. You can see it's a relatively young population because that's what we're dealing with. Again, we want to be very careful that we're trying to minimize the degree of ionizing radiation, as Dr. Chang indicated. So these are just showing our protocol. Again, the in-plane resolution and the through-plane resolution is going to be different based on the modalities. Measure all these appropriate angles that we talked about before, again, comparing CT to the osteo. We segment the bone, and now this is a creation of the 3D models. We create some filtering, we invert and threshold to give the CT-like contrast, and then do a seated green application apply. We generate these polygon meshes, and then we can create submeshes of the acetabular rim and the femoral neck. We're going to collect landmarks that are characteristic utilized to assess for this areas of impaction. And then we're going to look at femoral head spheres using an appropriate coordinate system. So again, the hip is going to be flexed to 90 degrees, and we're going to iteratively vary the degree of hip adduction and internal rotation. And so these are the data, and this is where it gets interesting. So femoroacetabular impingement is green. The blue patients are post-debridement, and the dysplastic patients are kind of in the gray. And you can see as we increase, you can see the differences that we see in all these different patient cohorts as we can develop kind of these in silico predictive models of the degree of motion, again, all now from just MR data. So again, you look at the scatter plot and you'll see there's no apparent correlation of any one measurement. So we couldn't really make any of comments about the predictions of range of motion based on any of the known measurements we had to routinely use prior to having these kind of techniques. So this is showing you changes in adduction and internal rotation. This is a patient with acetabular dysplasia. So again, they have huge range of motion, or can tend to be unstable, if you will. So you can see how this great degree of motion occurs. This is again proximity, whereas in the patient with femoroacetabular impingement, restricted range of motion. So not that much increase we can see in the, as we increase adduction and internal rotation. Now we can evaluate and show the surgeons how well they're doing, right? So we have a native hip, and then we have post-osteoplasty. So this, the surgeon can pat himself on the back and say, gosh, look at the range of motion that's been restored post the osteoplasty. But unfortunately, we can also show when they're not doing so well. So this was an incomplete debridement, and you see very little change in the increase of range of motion. And you can see actually on the 3D models, there's quite a bit of bone that was left there, unfortunately. So incomplete debridement. So one might ask, what's the fidelity of these meshes? So Ryan Breitner from our lab, who's a really wonderful computational scientist, did some really nice co-registered of these surface messages between the osteo, or what I still refer to as ZTE, and the CT, and showed really great reproducibility. So, and we can compare this comparison of the osteo to the CT-based model, and you can see how these look very, very similar back and forth. So number one, how do you get your orthopedic surgeons on board? Just make them aware that it even exists. I like to sneak it in and try to fool them, and then they'll call you and ask you, did you order a CT on my patient? You say, no, it's all MR data. Once you have that, you apply it to clinically relevant data sets. So all of the orthopedic trauma, for example, FAI, shoulder instability. We have shown that no single angular measurement of hip morphology characterized the osseous constraint, but this combination of in silico range of motion on ZTE will. Future directions will be things like creating even more 3D models, including soft tissue modeling, which now we can add onto the osteo images to give an amazing 3D rendering of a hip and simulate motion and prospective pre and post-operative evaluation. And I'd like to thank you for your kind attention. It was a pleasure to talk to you all today.
Thank you all for all the great presentation. So we'll start off the Q&A session. The first question is for all of you. Dr. Panel mentioned a little bit about one-stop shop MRI exam where you can see the soft tissue and the bone. We're wondering, how frequently are you using osteo today? And also, would you consider adding it to all your MSK exam? Maybe we'll start off with Dr. Eidingos first.
Well, yes, actually, I can easily say that we have incorporated ZTE to most of our routine protocols. I know that, there is this tendency to kind of perhaps overuse some new technology. I admit that, but still, and this also has to do with trying to kind of like weigh what these new techniques will bring. You want to make as many types of exams as possible where this can be really helpful. I know that this can perhaps somewhat change in the future, but for now, we are doing almost all of our protocols with ZTE just to see whether there are some subtle, if not always obvious, ways of incorporating the data that come from the ZT sequence. So I would say we are doing all of our MSK exams, most every one of them, let us say, on 3 Tesla with ZTE.
Mhm. Thank you. Dr. Potter?
So clearly on all of our trauma cases, our head of orthopedic trauma, David Helfett, puts ZTE on all of his requisitions now and has stopped doing CT for all of his rule out syndesmotic foot and ankle injuries. So clearly for that, elbow trauma, extremely helpful because elbow fractures can be really, really subtle. We do it in all shoulder trauma as well. We have used it for, as I mentioned, in the FAI and the shoulder instability cohort as well. We don't add it routinely to every case just because we do a lot of other things like parametric mapping and whatnot. But for the most part, we use it every single day.
Mm-hmm. Great. Dr. Chang?
We found the most value in adding it for potentially operative cases. I would definitely recommend working with your surgeons and clinical colleagues. If oZTEo could replace CT for them, and it's kind of a work in progress for them to get to that stage. But if there are instances where they want the CT anyway, for whatever reason, like resolution, then maybe spending the extra time on oZTEo might not be beneficial.
And lastly, Dr. Sandberg?
Yeah, and others have mentioned we routinely use it for trauma for pretty much any part of the MSK body, whether it's the extremities, the pelvis or whatnot. But as I mentioned in my lecture, that we perform it on every temporomandibular joint examination. We found that very helpful, and our rheumatologists have found it very helpful when visualizing both to them and their patients exactly what's going on. It's easier for parents to really see what's going on when it's easier for them to see like a CT-like image than an MRI. And so they're able to help the parents understand what's going on with their child. And we added on to all of our, quote unquote, tumor protocols whenever we're evaluating for some lesion that's involving the skeletal system. And we generally don't add it to, our general sports medicine case, and we're looking for just soft tissue injuries, such as in the knee, to save time. That's also a special consideration for pediatric patients, especially when at our institute, we have an exam, a targeted exam that takes 5 minutes. And so adding on another exam such as this, although it'd be great, is not indicated for those types of exams.
Mm-hmm. Great, thank you. And hopefully every DL will speed up the short portion of the conventional MR so that you can add oZTEo to it in more of those cases. The second question is 1.5T. Any experience on 1.5T? And is there any difference in contrast, or is it just an SNR difference?
Well, we have applied it both at 3T and 1.5. I would say that there's definitely a SNR difference, but we've gotten quality images of both field strengths.
Rob, you want to take the next one?
Okay, thanks, Maggie. So this will be another kind of general question to some of you. Maybe I'll just direct this one first to Dr. Eidenguz and also then to Eric. So we've seen great examples of the use of oZTEo for the pediatric and the pregnant patient populations. Do you see any other vulnerable populations, any groups of patients that you think are going to especially benefit from this non-ionizing technique?
Well, actually, as you point out, the basic target population would be definitely the pediatric and also the pregnant patients. But then I can tell you that, there are patients where, the non-compliance in terms of either claustrophobia or boredom or some movements or, some motion, in these patients, it's like a breeze for them to have a sequence without any noise there, without essentially any noise. So what you're doing is actually like you're putting a 4-minute or 3-4 minute extra time, but since it is not like the regular scans, like the regular sequences, where you have all the noise, it's kind of like a breeze for most of the patients. And this is something that was pointed out to me by not a few patients, actually, not only a couple of patients.
Excellent point. So that actually reminds us, because the Osteeo technique, which is based on the 0TE acquisition, is the same sequence that we use in our silent scan application, which obviously is intended for silent imaging. That's a great example. Thanks so much.
The next question is for Dr. Potter. So when our team and your team is working together to develop this sequence, we spent a lot of time on optimizing the signal uniformity and contrast so that 3D rendering could be more easily done. And we saw some pretty compelling cases today with 3D rendering. Do you see your referring physician starting to expect those, or how do you see the future for this in terms of 3D printing or pre-surgical planning?
So surgeons love 3D modeling, and I've spent 25 years telling them the exact data is on the axial acquisition. There's no additional data, but they love the picture, right? It gives them a sense of what they're looking at in the operating room. So, and patients, to Dr. Sandberg's point, patients love it. They love being shown exactly what it is and something they can recognize. So yes, and I would say, 3D printing is really taking off. So imagine, for example, a patient in their 20s with developmental dysplasia, now unfortunately requiring a hip replacement. We do routinely have done CT for that, and the CT develops a CAD model that goes to the orthopedic device company in order to generate a custom hip arthroplasty because their anatomy is so affected by it. So now we could do this all based on MR. And oh, by the way, look at clinically relevant things that affect arthroplasty success, including the integrity of the abductors and the surrounding soft tissue envelope, and develop a 3D printed model that we could then send to an orthopedic device company and render that perfectly planned, individualized arthroplasty.
And the next question is for Dr. Ellingos. What are the main trade-offs of this technique in comparison to CT?
Well, as we all know, most everything in life comes with trade-offs. And this is true also with ZTE. One has to admit that the best spatial resolution that we have in radiology is with X-rays or radiographs. But then with radiographs, we don't have much of soft tissue data or discrimination of the different structures within the soft tissues and also within the bones for that matter, because we are not getting the cross-sectional data. With CT, as of now, we have a better spatial resolution in comparison to ZTE, because with CT, computed tomography, we have a resolution like 0.625 in my department here. And with ZTE, we are like about between 0.8 to 1.2, 1.3. So in terms of spatial resolution, it is not as good as CT at first sight. But then you also have to realize the good point about, perhaps the best point about ZTE in general, because with ZTE, what you are getting is the best of the both worlds. In other words, you are getting bone contrast almost like CT, and then you're also having all these other soft tissue or contrast resolution, advantages with MRI in general. In other words, you are combining these two together in a one-stop shop imaging manner. And then what you are doing is you have the ability to cross-reference the landmarks from an actual CT-like image, actually, and then you are also comparing it with the other sequences. This is such a great facility. And this is something that I'm making use of almost on a daily basis with CT. So this is how I can sum up the trade-off there.
Yeah, especially that the soft tissue and the bone landmarks are co-registered within the same.
Yep.
And another question, this is for Dr. Chang. In the osteo image, the cortical bone is bright, but sometimes the tendon is still visible, not as bright, but kind of grayish. Is there any advantage, or would you consider as a disadvantage?
That's a really good point. Some tendons in certain orientations, such as when they're along B0, they have pretty short T2 star, similar to cortical bone. So they would be visible on the osteo sequence as well. I haven't seen an instance where a very normal tendon was confused for bone, so I don't see any disadvantages per se, but I can envision certain scenarios where it might be useful to use osteo to distinguish between a very normal tendon and a subtly abnormal tendon with very high sensitivity.
Great, thanks. The next question is for Dr. Potter. I think you touched on that a lot during your pitch as well. So how do you see this osteo technique drive satisfaction for your referring physician and also referral volume to your site? Especially in the New York market, it's very competitive.
Yes, in a quick word. So I'm an MR radiologist, but I'm responsible for the business model of the whole department. So that includes CT. So someone may ask, well, isn't this affecting your CT volume? The difference is that, let's say a patient comes in needed for an ankle MR. They have a soft tissue injury, they rolled their ankle. There are more high field scanners in a 10 block radius, and there are hot dog kiosks. So it's an incredibly competitive market. If I could say to that referring clinician, I can do all this with MR, you don't need to get a concurrent CT, I will grab more MR business. So yes, I may not get a concurrent CT on that patient, but it will drive and bring more MR business. The other thing I can tell you in New York City, people are incredibly cognizant of radiation safety. They want to know dosages. They want to know exactly how much radiation they've gotten. We're constantly talking to patients and letting them know, trying to mitigate the radiation burden. So this is a huge draw from the patient population.
Great.
Okay, well, let's shift to a question for Dr. Chang. So the rubber hits the road. In the long run, how do you see osteo impacting healthcare costs? Can you opine on that?
Yeah, undoubtedly, it's going to have a positive benefit if used properly. Certain cases where CT would have been performed, if osteo can replace the CT, that would very clearly benefit healthcare costs.
Okay, great. Okay, so then I think maybe our final question for Dr. Sandberg. You obviously deal with a lot of pediatric patients and their families. Is this a technology that you feel that they need to know about? And do you envision facilities such as yourself marketing these capabilities to patients and their families directly? Can you speak to that? How do we get the population to know about this capability?
Absolutely. I really feel that families do need to know about this. You know, we mentioned to our orthopedic surgeons and to all of our referring physicians that, you know, this technology has the potential to reduce the number of CT examinations, you know, a patient might obtain. This is especially important for those patients. And, you know, there's many pediatric patients that have, you know, chronic diseases and they require follow-up imaging and a lot of imaging evaluation over time. And as other panel speakers have mentioned that, you know, parents are very cognizant on radiation exposure, especially in this modern age, especially where all of our institutes are. And, you know, by combining both, you know, having a CT-like image as part of an MR, this would obviously reduce the amount of ionizing radiation. Also, you know, another benefit, and we've discussed this with referring physicians, and we're going to add it to our website, is, you know, this has the potential to avoid anesthesia time. Another thing that's very concerning for parents is the anesthesia time. And so, you know, oftentimes for our patients, especially younger patients, you know, we had to get an MR scan, but for pre-surgical planning, you know, classically they would get a CT scan. So they had to transfer the patient under anesthesia from the MR scanner over to the CT scanner. So that would, greatly reduce the anesthesia time. And, lastly, I encounter, I answer phone calls. I talk to parents all the time over this radiation exposure. So overall, having a combined effect would, greatly impact patient care for a positive. In terms of marketing capabilities, I think taking advantage of your institute's webpage is very important. I know from personal experience from my family that, before they go anywhere, they go look on the website and go search around, see if it looks legit, just as simple as that. So really having a professional webpage really can bring that out there. And to reach out to even your local physicians, not only the orthopedic surgeons, your rheumatologists, but your local, for my instance, local pediatricians and local community healthcare.
Great. Well, that was a great answer. Thanks so much. That was very comprehensive.
This concludes our panel discussion. Again, thank you so much, Dr. Chang, Dr. Sandberg, Dr. Edengos, and Dr. Potter for sharing their experience of osteo with us. If you're interested in learning more about osteo, you can follow this link to the MR AuthorWorks website to learn more about all our cutting-edge MR MSK applications, such as oZTEo, Hypermaverick, and Air Recon DL. In addition, we recently have a sports medicine-focused Signal Pulse publication, and it contains a few articles that showcase various clinical utilities of the ZTE technique. There's also an osteo technical white paper that we offer a recommendation for protocols, tips, and tricks for various anatomies. In that article, you will also find a list of peer-reviewed journals that uses the GE0TE bone imaging sequence. To date, we have 11 peer-reviewed publications applying this technique in various areas, including spine, shoulder, hips, pediatrics, and more. If you're interested in producing 3D volume render image, there's also a handy 4-minute video online that goes through step-by-step instructions on how to perform realistic volume rendering. Last but not least, we want you to tell us what osteo can do for you and your patients. We're very excited that we are launching an image competition for osteo. You can simply share your interesting osteo cases via LinkedIn, Twitter, Facebook, or Instagram with the hashtag GEMR image competition and osteo MR bone imaging. You can include a few sentences on the clinical history and diagnosis, and remember to submit it before August 31st, 2022. So looking forward to seeing some exciting cases from you guys. Lastly, thank you very much for joining us today in the webinar, and we hope this shows you what osteo can do for your patients and how you can incorporate osteo in your patient care. Thank you very much.